I'm Dr. Nikhil Tandon. I'm Professor of Endocrinology at the All India Institute of Medical Sciences in New Delhi. And today we will be conducting this session in which I shall discuss aspects pertaining to the screening, diagnosis and management of diabetes with special reference to the primary healthcare setting. What we all know is that diabetes is a disease in which the body either does not produce adequate amounts of insulin or there is resistance to the action of insulin in the tissues. Insulin, as we all know, is required specifically to facilitate the movement of glucose into the cells and then utilization of glucose by the cells for the sake of energy production. And therefore, it has a critical role in the entire energy homeostasis of the body. There are two or three major types of diabetes. One which is called type 1 diabetes, which in the years gone by used to be referred to as insulin-dependent diabetes. The other, which is type 2 diabetes, which previously was referred to as non-insulin dependent diabetes. Now, these older terms still carry a bit of relevance because type 1 diabetes patients have to get insulin from outside because there's an absolute deficiency of insulin in their body and it is required for their survival. So such patients, unless they're given insulin as an injectable form as it is available today, will end up with high sugars and acute metabolic problems which include diabetic ketoacidosis and if left untreated can result in death. So they are dependent on insulin for treatment and survival. Type 2 diabetes or non-insulin dependent diabetes is usually managed by a combination of lifestyle measures and oral agents, but towards the longer duration of this disease, it is not uncommon for them to require insulin, though they are not dependent on insulin for their survival. The third category of these diseases is called gestational diabetes, and which is a disease which becomes apparent or a condition which becomes apparent for the first time in the pregnancy of a woman. So it's basically defined as when hyperglycemia is diagnosed for the first time during pregnancy. A significant proportion of these women will revert to a state of normal glucose tolerance after delivery, but similarly a significant proportion of women in the years to come will again progress to type 2 diabetes. And therefore, gestational diabetes is a harbinger of future type 2 diabetes, and therefore not only must it be managed during pregnancy, but the woman must be forewarned that it is a predictor of type 2 diabetes in future. Right. So type 1 diabetes usually occurs in the younger age group, usually in children and adolescents. Most of these patients will occur in the first 2 decades of life, very rarely before the first year of life, but usually between the 1 year and about 15 to 20 years of life. This, as I mentioned previously, often presents abruptly and is associated with an absolute deficiency of insulin. It's an autoimmune disorder. Basically, our own immune system turns against the pancreatic beta cells, causing a destruction of these beta cells and therefore causing a production and then a cessation in the ability of the system to produce insulin, thereby suggesting that all these people must be given insulin from outside. While the family history is relatively rare, between 3 to 6% of children or adolescents with type 1 diabetes will have parents or other first-degree relatives who also have this particular disease. In addition to type 1 diabetes, they may also have other autoimmune disorders which could be involving the endocrine system, but also can affect the other systems of the body. And features which are more characteristic of type 2 diabetes, such as obesity and acanthosis nigricans, are extremely uncommon in children and adolescents who develop type 1 diabetes. As I had referred to earlier, if left untreated, the hyperglycemia can progress significantly and result in the production of ketones and ketoacids. These are byproducts of fat metabolism and are responsible for creating metabolic acidosis in the body and can if left untreated, result in the death of the individual. Type 2 diabetes is clearly the commonest type of diabetes. It occurs usually in older individuals. Once upon a time, it was extremely rare to find it in people less than 40 years of age. Unfortunately, type 2 diabetes today has started occurring earlier and earlier, such that we are even seeing people in their second decade, that means adolescents, also developing this disease, which often makes an adolescent presenting with diabetes a confusing situation for the doctors, who have to then put in a bit more effort to differentiate whether that adolescent had type 1 or type 2 diabetes. But as I said, it's commonly after 20 years of age, and it can usually in the third or fourth decade of life. It was previously referred to as non-insulin dependent diabetes because people were not dependent on insulin for survival, but it could still, over a period of time, require the patient to take insulin to get blood sugars under control. The disease gives a slow progression. So there is also an intermediate phase of type 2 diabetes, which is called prediabetes, which is impaired glucose tolerance or impaired fasting glucose, in which a person is gradually transitioning from a normal state of glucose control to an intermediate state of glucose control, and then finally progressing to type 2 diabetes. The advantage of mentioning this here is that this state of prediabetes, if picked up, can be used to intervene so that we prevent or at least delay the progression of the onset of type 2 diabetes in these individuals. Family history is quite often strong, and 20, 30 or even more percent people will have a family history of type 2 diabetes. If you have both parents with type 2 diabetes, the likelihood of a child developing type 2 diabetes may be as much as 60 or even 70%. Obesity is a very, very common factor. Other coexistent metabolic abnormalities like abnormal lipid values, abnormal blood pressure, increase in waist circumference, abnormal lipid parameters are also commonly seen. And acanthosis nigricans, which is this velvety black discoloration often seen at the nape of the neck and the axilla, again is not uncommonly associated with the obese people who have type 2 diabetes. With this background, it's important for us to know when a person is likely to be at a high risk for diabetes, because people like that can be warned so that they can take appropriate lifestyle measures to either prevent it altogether or delay the onset of disease. Being overweight or obese is very, very important as a cause or an association of this disease. Similarly, in an Indian setting, we find that the person may not look significantly overweight, but has a little increase in the waist circumference. And therefore, central obesity over and above absolute obesity also contributes to a higher risk of developing diabetes. Physical inactivity or sedentariness is again an important contributor. So people who are likely to exercise less are more likely to develop type 2 diabetes than those who exercise more. Other associations, as I mentioned, include high blood pressure, high cholesterol levels, a family history of either first-degree relatives, parents or grandparents are again at higher risk. Women who have had gestational diabetes during their pregnancies, and or if they've had babies who have had a high birth weight, even if diabetes was not checked for in that pregnancy, become people at high risk. When should we suspect that somebody has got diabetes? Now, as I said, type 1 diabetes is often very abrupt and very severe, and therefore it's often manifest, quite easily diagnosed, and it's usually not a diagnostic dilemma because a person is coming with a significant amount of osmotic symptoms, which include excess thirst, excess urination, and often excess hunger. The same symptoms will also occur in type 2 diabetes if the situation is left untreated for a period of time. But other markers which we must be careful about include poor healing of wounds, recurrent infections, especially skin infections, urinary tract infections, infections of the genital areas and vulvovaginal infections in women are all important things. Unexplained lassitude, malaise, fatigue, and weight loss are also possible associations of uncontrolled hyperglycemia, and people presenting with that must therefore be evaluated for diabetes. In men, erectile dysfunction can also sometimes be the first manifestation of uncontrolled hyperglycemia or diabetes. Now, the criteria for diabetes have changed a bit over a period of time, but have been relatively stable now for the last 20 years. Otherwise, it was sometimes becoming difficult to remember what the cut points are. Essentially, there are two time points which are important in understanding. One is a fasting state, and when we say fasting glucose levels, we're really looking at somebody who's been fasting for at least 8 to 10 hours. Somebody who's had a fast for only 6 hours is not a good person to check for diabetes. So a fasting venous plasma glucose of 126 milligrams per deciliter or more, that is greater than equal to 126 milligrams per deciliter, is a cut point for diabetes. There is another cut point which is in the post-glucose load state in an oral glucose tolerance test. So an oral glucose tolerance test involves somebody given 75 grams of anhydrous glucose mixed in about 250 or 300 ml of water. That's essentially a large glass of water to be drunk over 5 minutes. After drinking that water containing glucose over 5 minutes, the person is expected to wait and sit in one place for at least 2 hours and should not be doing any physical activity or smoking during that period. 2 hours after the glucose load, if the venous plasma glucose is 200 milligrams per deciliter or more, it's again considered to be a value consistent with the diagnosis of diabetes. So let me repeat this. A fasting venous plasma glucose of 126 milligrams per deciliter or more and a 2 hours post-glucose load venous plasma glucose value of 200 milligrams per deciliter are consistent with the diagnosis of diabetes. Now, in this, there are additional issues. Sometimes we don't do a venous plasma glucose. We measure a capillary blood glucose. While that is not really advisable, you can take a capillary plasma glucose in the fasting state to be roughly equivalent to a venous plasma glucose. But in the post-glucose load state, that is in the 2-hour value of the GTT, if you're looking at a capillary blood glucose, then the value of interest is 220 milligrams per deciliter and not 200, because a capillary blood glucose of 220 is approximately equivalent to a venous plasma glucose of 200. Having said that, whenever possible, it is preferable and ideal to use a venous sample and measure the glucose in the venous plasma. Now, I mentioned this about the diagnostic criteria for diabetes. There are two other conditions which are important. Both were previously and are still referred to as prediabetes. One is, in the fasting state, if the venous plasma glucose value is 110 milligrams per deciliter or more, but less than 126, it's called impaired fasting glucose. Similarly, if in the 2 hours post-glucose stage, it is more than 140 milligrams per deciliter, but less than 200 milligrams per deciliter, it is called impaired glucose tolerance. So IFG is 110 to 125 milligram per deciliter, and IGT is 140 to 199 milligram per deciliter. These qualify the person to be a person who can be referred to as having pre-diabetes and would be a person of interest as regards lifestyle modification is concerned. Now, management of diabetes, now that you've made a diagnosis, has 2 or 3 very important aspects. People tend to believe that the first thing you do when you're diagnosed with diabetes is to start medication, but that is absolutely not the right way. There are 4 key aspects for managing diabetes. Diet as number 1, physical exercise as number 2, medication, which could be oral or injectable, as number 3, and monitoring response to therapy, whether it's cell phone monitoring of blood glucose or laboratory evaluation, is number 4. So these are, imagine there's a table. These are the 4 important legs of the table required for managing all diabetes: diet, physical activity, medication, oral or injectable, and monitoring. The initial assessment for diabetes as prescribed in the government norms today for someone visiting a government health system ideally should be done at the level of the primary healthcare center or at the PHC. And this management requires an assessment of a history, a physical examination, a management plan, and future visits to be decided. Now, the initial examination, in terms of history, there are certain points which are fairly important. I'll talk about that. One, why was that person even tested for diabetes? Is it part of the government's universal health screening program, which could well be? But remember, not everywhere has this program yet been initiated. So some people may actually get tested because of the previous efforts at opportunistic screening, or they may get tested because they actually have symptoms suggesting of uncontrolled sugars, which I've already mentioned, like elevated glucose, like increased thirst, increased urination, increased appetite, and or weight loss. Why was this test done? What did that test report say? What is the value? If this person is newly diagnosed, then you have to understand the symptoms better, because very often the patient is not so worried about the glucose value. They want themselves to become symptom-free. Once that is done, a physical examination to look at all systems of the body becomes important, because diabetes can affect any system of the body. And I will detail that in a moment from now. After assessing the blood glucose level, it is also important to communicate to the person that diabetes doesn't merely mean elevated sugars. People with diabetes at higher risk for high blood pressure, so blood pressure should be measured, high cholesterol, so wherever possible, either at the primary health center or during a subsequent visit to a community health center, lipids should be evaluated. And the last thing which must be emphasized is that our concern for people with diabetes is the development of chronic vascular complications. These chronic vascular complications could either be microvascular complications, that is, involvement of the retina or diabetic retinopathy, involvement of the kidney or diabetic nephropathy, involvement of the nerves or diabetic neuropathy. Now, because diabetes can be, especially type 2 diabetes, can be an asymptomatic disease, just because we are diagnosing that person today, it doesn't mean that they have had disease only starting today. There are people who could have had diabetes for several years and have remained undiagnosed. This also implies that they could actually have developed a complication of diabetes even before they were diagnosed to have disease, because they've had relatively poor symptoms or lower symptoms which are not picked up, they've never been screened, and they may have had diabetes of 5, 7, or 10 years, which is enough duration for them to develop a complication. I've already mentioned to you the complications which are microvascular, but there are similarly macrovascular complications. These macrovascular complications include cardiovascular, which include involvement of the heart, cerebrovascular, which involves the brain, and also the importance of a diabetic foot developing because of a combination of vascular disease and nerve disease. So just to take you through this once again, because this is very, very important, the key history that we must ask is symptoms, the duration since the onset of symptoms, was there any precipitating factor? Very often infections, stress, a recent change in dietary habit, a recent change in physical activity. Not uncommon, somebody is physically very active, develops a knee joint pain, and therefore they can't be physically active, or they change their job profile from a relatively more active job to become a sedentary worker. All of this can be important. The symptoms of micro and macrovascular complication, including changes in visual acuity, but remember here that you can have significant retinopathy without any change in visual acuity, because unless the fovea is involved and the macula is involved, there may be no impact on central vision. You could have renal involvement as manifest by edema. There could be other causes for fluid retention which may cause breathlessness. There could be a heart involvement which could therefore cause angina or dyspnea or effort intolerance. You could have claudication because of impaired blood supply to the foot, and therefore asking somebody if they develop foot pain or calf pain or thigh pain on walking a distance. They may develop paresthesia. They may actually develop numbness. And they also may develop erectile dysfunction in the case of males. Checking for hypertension, checking for drugs, because some drugs, somebody who's been on steroids for, let's say, asthma, for an allergic complaint, may also have precipitation of diabetes. Change in diet from a traditional Indian high-fiber vegetarian diet to a processed food, junk food, fast food eating out sort of diet is again an important factor. And it could again be in terms of, as I said, change of the type and frequency of physical activity. A family history must also be asked for. And this could be, very often we find that patients turn and say, no, nobody in my family has diabetes. But if you start asking them one by one, is your father having diabetes? They say, well, my father actually just before he died developed diabetes. So you often have to get this out by asking individual questions. Sometimes they may have family members with diabetes, but they may not know. So really you shouldn't assume that there's nobody with diabetes unless this question has been asked very carefully. Similarly, a history of premature coronary artery disease or premature cardiovascular death must always be inquired in the family members. On physical examination, the weight, the height, so that you can calculate the BMI, waist circumference, very importantly, because you need to see a measure of central obesity. Acanthosis nigricans, which as I referred to earlier, is a black velvety discoloration of the skin, often in the axilla or in the nape of the neck and sometimes even elsewhere. Checking for the blood pressure, checking the peripheral pulses, looking for corns and callosities because they change the pressure on the feet and therefore can expose a person to developing foot ulcers. A fundus examination, auscultation of the chest, the heart, including heart sounds and presence of any evidence of congestive heart failure, and an evaluation of the peripheral nerve system and a palpation of the thyroid are all important parts of the physical examination of a person with diabetes. The initial management, as I said, includes the pharmacotherapy for hyperglycemia and for comorbid conditions. But before we talk of that, the most important thing in the beginning is diet and physical activity. Very often if you ask somebody, they say, no, but I don't take sugar in any case. But eating sugar or not eating sugar is not the only aspect of dietary control. The key aspects of diet management in a person with diabetes are quantity of food, nature of food, the timing of intake of the food, and the spacing and the frequency of meals. So you can be taking the right amount of food, but if you divide that into two major meals, you will still be exposing the person to a higher caloric load in a single meal, which is not good. You may be taking multiple meals, but they may be clustered together because you have a late breakfast and early lunch, and because of various beliefs, you may end up having dinner before sunset. So again, that is bad. You may be taking small amounts of food, but you may be taking calorie-dense foods or sugar-containing foods. That is bad. You may be eating meals which are just inappropriate in terms of quality. So we need to emphasize all four aspects: total quantity of food, the type of food material which has been taken, how frequently and how many number of meals. We normally are looking at 3 major and 2 or 3 minor meals, and the spacing between meals becomes very, very important. In terms of physical activity, again, it's important for us to understand that we're not looking at anything exotic. As long as somebody does an aerobic form of physical activity, which could be just regular walk, which is brisk. If a person is not accustomed to walking, they can even start with 10 minutes in a day, but gradually build up, maybe half an hour a day. If you want to lose weight, that perhaps should be increased to 45 minutes in a day. For younger people, you can target up to a speed of 9 to 10 minutes for a kilometer. For older individuals, the speed can be slowed down. One easy way of checking is if you're walking with somebody and you can speak and have a normal conversation with that person while walking. That means you're not breathless enough, which means you're not pushing yourself in terms of the pace at which you're walking. Again, never walk on a full stomach. In an older person, it's always better to ascertain that there is no underlying heart disease. If somebody wants to start jogging, again, underlying heart disease and evaluation for a fundus to see that there is no proliferative retinopathy are actually recommended so that you don't cause more harm than good under those circumstances. In terms of medication, I think simple medication is very easy to do and is the best. The first line of therapy or the drug of first choice is metformin. And unless you're suspecting a contraindication to metformin like renal insufficiency or congestive heart failure or ongoing hepatic insufficiency or jaundice, I think metformin can be safely given to anybody. The other groups which is often used are sulfonylureas. They are insulin secretagogues. That means they cause a release of insulin. They can therefore be associated with hypoglycemia, and they have to be therefore, that side effect has to be explained. In a younger patient, even agents such as glibenclamide can be used. But in older people, we tend to avoid glibenclamide because of its tendency to cause hypoglycemia, which may have significant consequences in an older individual. Remember that therapy doesn't start and stop with management of glucose. If the person has a high blood pressure, then you're looking at either an ACE inhibitor or an angiotensin receptor blocker, so a ramipril or a losartan or a telmisartan, or you can look at agents such as calcium channel blockers and or diuretics such as a low dose of hydrochlorothiazide. For cholesterol, the agent of choice remains statin, and again several relatively inexpensive statins such as simvastatin and atorvastatin are available, so we can't manage. So to summarize, and I will talk to you more about this as we go along, metformin as a first line of therapy, ACE inhibitors, ARBs, or amlodipine with a small dose of hydrochlorothiazide as the 3 or 4 agents which you can look for blood pressure control, and statins for cholesterol. I think it's important to have a sense of what our target for control should be, and I think for that target of control should not only be known to the doctor but communicated to the patient. Because the patients may get their test done elsewhere, and they should therefore know that if our target of control is, if our blood sugar values or our cholesterol values or our blood pressure values exceed that target, they should report back immediately. So we normally say a fasting glucose value of less than 120 milligrams per deciliter, a postprandial. We don't need to do an oral glucose tolerance test subsequently. We are happy just doing a post-meal value. And remember here, it's important that if somebody is on medication, the post-meal value has to be along with the medication that they are using. So, supposing I'm taking 500 milligrams of metformin with breakfast, my fasting value will be without food, without metformin. After I give my fasting glucose, I will take my breakfast, take the metformin tablet, and 2 hours later, I will be checking. I'm no longer checking whether the person has diabetes or not. Now I'm checking whether my intervention of diet, physical activity, and metformin is adequately controlling the blood glucose or not. In terms of the post-meal value, as I said, the control, we are looking at somewhere between 130 and 160. For HbA1c, which gives us an idea of control over the 3 months, we're looking at a target of somewhere between 6.5 to 7%. And HbA1c is a very useful test if it can be done easily, because it gives us a sense of what the average control is like. Now, you may hear different versions of what should be the target HbA1c, but 6.5 to 7 is usually quite good. For older people, those with comorbidities who have already got renal insufficiency, who have congestive heart failure, who have a tendency to fluctuating sugars because of the nature of their work, you can actually have milder control values. For total cholesterol, you're looking at a value of less than 180. For LDL cholesterol, which is the bad cholesterol, you're looking at values less than 100. For triglycerides, you're looking at a value of less than 150 milligram per deciliter. And for HDL cholesterol, you're looking at a value of more than 45 milligram per deciliter in men and more than 50 or 55 milligram per deciliter in women. And you're looking at a blood pressure target of 130, 135, and as systolic, and 80 or 85 as diastolic. These values keep changing off and on with different recommendations. So I'm giving you a general sense. And, as long as you're in this particular range, you should be all right. Let me just sort of apprise you a little bit more about glycosylated hemoglobin, because increasingly there'll be an effort to get glycosylated hemoglobin or HbA1c done in the community health centers, and facilities should be increasingly become available. Now, it gives you an idea of control of glucose over 3 months, because that's the lifespan of an RBC, but it doesn't give you an equal idea of all 3 months. So the HbA1c done on the 1st of May of 2018 will disproportionately give you information about the preceding month. So about 50% of the A1C is contributed by the month immediately prior, maybe 30% or so of the month which is 2 months before the test, and about 15 to 20% from the first. So if you have very good control in the immediately previous month, you're likely to have a better A1C than somebody who has very good control in the first month, but not as good control in the subsequent 2 months. Let's now look at the various medications, and I will prefer first to talk in some level about metformin. Now, we don't know how metformin really works. It's supposed to be an agent which affects an enzyme called AMP kinase, which is perhaps not relevant for clinical practice at the moment. But what is important to understand is it sensitizes the tissues to the action of insulin. It predominantly affects the liver and to some extent peripheral glucose as an insulin sensitizer, or something which diminishes insulin resistance. Now, I'm saying this repeatedly because that means that the likelihood of metformin causing hypoglycemia or below normal glucose becomes less. Now, that some people complain of a gastric irritation when they take metformin, especially the larger doses of metformin. The way you can handle that is twofold. One, the sustained released forms of metformin often are less irritating to the stomach. Secondly, since it's not being used to cause insulin release, you can give it at any time. It doesn't necessarily have to be on empty stomach. You can actually give it on a full stomach immediately after a meal, and that minimizes gastric irritation. The lowest prescribed dose is anywhere between 250 to 500 milligrams, but you can go up to about 2 grams per day. And in a sustained release preparation, you can give it twice a day, up to a maximum of 1,000 milligrams once a day, 1,000 milligrams twice a day. So that means 2 grams. And you can up titrate or down titrate the dose by looking at a response over 2 to 4 weeks. We normally don't start lower than 500 milligrams, and usually somewhere between 500 and 1,000 milligrams per day. It doesn't cause insulin release, and therefore it doesn't cause hypo, and therefore it doesn't cause excessive food intake, and therefore it doesn't cause weight gain. Therefore, it's a very useful agent as monotherapy, and as I said, as a first line of therapy. It can be combined with any other anti-hyperglycemic agent, including insulin. And again, therefore, it becomes a drug which is quite useful. We must have knowledge about the likely contraindications. And this is important because there's this fear in our minds that metformin is associated with lactic acidosis. Well, metformin may be associated with lactic acidosis, but it often happens only, and even then extremely rarely, if it is given in a condition when it is contraindicated. It used to be said that if serum creatinine is more than 1.4 milligrams per deciliter in women or more than 1.5 milligram per deciliter in men, it should not be used. The recommendations have changed slightly, and for most of us who now rely on phones, smartphones and apps, you can actually do a calculation of what is called the estimated GFR, for which multiple formulae like the MDRD and the GALT are available and can be downloaded onto your phones as an app. Using these apps, you can calculate the eGFR or the estimated GFR in an individual. If the eGFR is more than 60 milliliters per minute, you can give metformin and you can give it without any consideration. If the eGFR is between 45 and 60 milliliters per minute, you can give full dose of metformin, which includes up to 2 grams, but you need to have maybe every 3 months a check of creatinine. If it's between 30 and 45 milliliters per minute, you can give metformin, check creatinine regularly, but not exceed a dose of 1 gram. If somebody is not already on metformin, I would recommend that don't start it if the GFR has fallen below 45. If somebody's GFR is below 30 milliliters per minute, if they are already on metformin, discontinue it. If they are not on it, don't start it. I know this is a very complicated sort of thing, but it's important to remember that the 3 cut points of relevance are 60 milliliters per minute or more, give it without difficulty. 45 to 60 can give with better monitoring of creatinine. 30 to 45, if not already on it, don't start. If on it, don't exceed 1 gram. Below 30, do not give at all. Alcohol abuse, congestive heart failure, hepatitis, use of large volumes of radiographic contrast medium are other conditions when you will not give it. There is again this ongoing debate about whether you can give metformin in a person who has to undergo general anesthesia. We used to recommend stopping it for at least 48 hours. Now, most people have started saying omit the dose the previous night and that should suffice. There used to be another agent in the same category of drugs which is called biguanides, which is no longer available. That was fenformin, and therefore I will not talk to you about it. Shifting to the other category of agents which are likely to be available at our primary health care levels, the PHCs and CHCs, is glibenclamide. Now, glibenclamide comes from a category of drugs called sulfonylureas. These are insulin secretagogues. That means they act on the pancreatic beta cells to cause release of insulin. Now, they will act whether or not the blood sugar is normal, low or high, and therefore they may be responsible for hypoglycemia. If somebody gets a sense of hypoglycemia, they may end up wanting to eat something because they want to counter the hypoglycemia, and therefore these agents may be associated with weight gain. So glibenclamide as a long-acting sulfonylurea may be associated with weight gain, and therefore one has to be careful. But you therefore start at a small dose. The smallest dose prescribed is 2.5 milligrams, and you can go up to a maximum of 20 milligrams per day. You can give it in 1 or 2 split doses. It's a long-acting agent, and you don't need to give it more frequently than twice a day. Since we want it to act by releasing insulin, we therefore ideally give it 20 to 30 minutes before the meal so that it acts on the pancreatic beta cells, causes insulin release by the time the meal has been taken. I said that the total dose varies from 2.5 to 20 milligrams. By and large, the incremental benefit is good till 10 milligrams. Increment from 10 to 20 does give benefit, but not to the same extent as that from 2.5 to 10. So essentially for all sulfonylureas, the increase in benefit is maximum till the half or is best till the half maximal dose, and then tends to plateau off. So if you're not getting a very good response till you've reached a half maximal dose of a sulfonylurea, it's best to add another agent than to persist too much with the sulfonylurea. As I said, you have to be cautious. It can cause hypoglycemia. So in older patients, one needs to give it with care. And I would not recommend that you give it before once the person is about 60 years or older. People who are likely to have an irregular meal pattern, again, should not be given this particular agent. However, it can be given as a monotherapy or in combination with any other agent. So it's a relatively enabling drug in that process. The general guidance which we should remember while looking at oral agents are that the treatment should be individualized, and whatever we've talked about are general guidance, and you must also look at individuals in terms of their age, their weight, their lifestyle, their comorbidities, their other medication, and any other conditions or acute illnesses that they are facing. The necessity of diet and exercise must be emphasized, as must be the necessity of periodic glucose monitoring. So once upon a time, we used to feel that in a person who is not obese, we may start with sulfonylurea in preference to metformin. But currently, people believe that irrespective of whether the person is obese or has a normal BMI, maybe we should always start with metformin and then add a sulfonylurea later. If a person comes to you with a very high glucose value, it sometimes is better to start that person on insulin because it brings down the glucose fast, and once the glucose values have reached a near normal value, you can then consider switching from insulin to oral agents. Now, people have to be reassured that we're not permanently putting them on insulin, but it's just a strategy to control sugars faster, because you may end up with a situation called glucotoxicity, which means that in the presence of very high glucose values, the same oral agents which should have otherwise worked don't do such a good job. Right? The other issues are in the presence of very high glucose, you are obliged to look for urine ketones, because the presence of ketones also demands that we must give that person insulin. And I also would like to remind you that evaluation at the earliest of a renal function is extremely useful, because your decision to give metformin is also contingent on that. The people who are obese and have diabetes, as I said, very, very clearly can happily be started on metformin without any difficulty. Right? Can we combine oral agents with insulin? This does happen, but usually happens later in the stage of disease, when you're giving 2 or 3 oral agents, one biguanide, that is metformin, sulfonylurea, or any of the other agents which could include a glitazone, or sometimes even the more expensive newer agents like dipeptidyl peptidase 4 inhibitors or DPP4 inhibitors, or as we call them as gliptins, but the sugars remain uncontrolled. It may not be a bad idea to combine them with a small dose of insulin, and you can actually start with just a single dose of an intermediate acting insulin like NPH. Now, this is especially useful if fasting glucose is high, but the post-meal value is not much higher. So if somebody has a fasting value of, let's say, 200 milligrams per deciliter, and the PP is only 230, 240, 250, it becomes obvious that if you can pull the fasting value down by 70 or 80 and make it 120, the PP value will also get dragged down, and giving a single shot of an intermediate acting insulin can become very useful. However, if there's a very large gap between fasting and PP values, it's unlikely that just giving an intermediate acting insulin will be sufficient, and therefore you may have to consider a pre-mixed insulin which contains both a short and a long-acting or an intermediate-acting component to control the bad pre-meal values and the bad post-meal values. Okay. Now, it's also important, if we are in a primary care facility, to take a decision as to when a patient should be referred to a secondary care facility like a CHC or a subdivisional hospital or a district hospital. Clearly, if with two agents of like a sulfonylurea and a metformin, sugars are remaining uncontrolled, I think it's important to seek a specialist advice. If you have significant comorbidities like uncontrolled hypertension, like chronic obstructive airway disease, like creatinine which is rising to suggest poor renal function, you should refer the patient. If there's a severe infection, like symptomatic urinary tract infection, which is even giving symptoms suggestive of pyelonephritis like a flank pain, cellulitis, which is looking like it's spreading, please refer the patient to a CHC. Unresponsive urinary tract infection, bad diabetic foot, anything which in your assessment as a physician requires intravenous antibiotics is a good indication to send a person to that. Recurrent UTI, even if the individual episodes were enough and were controlled on oral agents, is again an indication to refer a patient to a CHC. And ketones in the urine, again call for a referral to a CHC. I've mentioned the concept of diabetes education and the concept of lifestyle management at many points during the course of this session, and I'd like to once again reinforce the need. Now, we're not looking at, very detailed advice, but broad principles of diabetes management, which include issues pertaining to the diet and physical activity, must not only be mentioned at the time of first contact, but reinforced with every follow-up visit. Very often people will turn around and say that, you told me not to have sugar and I'm not having sugar, but that's not what you said. You explained to them very carefully about quantity of the diet, nature of what you're eating, the number of meals and therefore the quantity per meal and the spacing. Patient education therefore is critical. At the PHC, nurses, the A&M or the multipurpose worker can be adequately trained to deliver the very, very broad principles. We're not looking at, detailed evaluation or detailed information, but we're at least giving them a conceptual framework of what a patient should understand and what the patient can be expected to implement easily and practically on a day-to-day basis. These topics for patient education should be covered in the initial visit and must also be reinforced. Now, in the initial visit, one must tell the person what is diabetes, why does it occur, what are the key aspects of diet and exercise, why will we give you an oral agent if required, what are the symptoms of uncontrolled blood pressure, and what is the importance of managing not only glucose, but other things like cholesterol and blood pressure, and very, very importantly, an area which I unfortunately haven't mentioned at all till now, tobacco cessation. Tobacco of any sort, whether it is chewing tobacco, inhaled tobacco, smoking tobacco, smoking by hookah, smoking by bidi, smoking by cigarette, smoking in any other form, is an absolute no. Now, anybody who takes tobacco and has diabetes increases the likelihood of heart disease by at least 2 or 3-fold, if not 5-fold. And therefore, the message for tobacco cessation must be given initially and at every visit thereafter. In the follow-up visits, the importance of glucose control, the issue about chronic micro and macrovascular complications, issue about foot care, reference to other agents if you anticipate that these will be required, also reference to insulin therapy if you can see that a person may need it in the horizon. It is always useful to warn a patient that we are trying to control you with oral medication, we will continue to try and do that, but maybe over the next few months, if the sugars remain so uncontrolled, we might be compelled to give you insulin. That prior warning helps the patient reconcile to the plan of giving them insulin. The other area which becomes important, especially in girls who have type 1 diabetes, And unfortunately, now in younger women who've also developed diabetes, which could be type 2 diabetes at a much, much younger age, is the fact that they should have absolutely good glucose control before they conceive, and ideally, therefore, before they become pregnant. The little sensitive area which has to be broached is, especially in a child or a woman who has type 1 diabetes, is that this is an area which ideally should be discussed with her prospective groom, and if required, with her prospective in-laws. And similarly, that's for the pregnancy part, but even boys who have type 1 diabetes, or boys who have, or adolescents or young adults, young male adults who have type 2 diabetes, should share this information with their spouse. In an era of transparency and full disclosure, I think it'll be inappropriate for a marriage to start without that being done. Now, I mentioned the concept of foot care advice to you, and I think this is something which becomes critical for us in a culture which very often has barefoot walking, especially inside the house, especially inside the puja room, definitely in places of worship, and this is an area which must be informed. So the foot is an area which the person has to look at even more carefully than the face, because inadvertent cuts, wounds, blisters, ulcers or callosities can be portals of infection and can result in significant morbidity, and unfortunately can also lead to mortality. So a person with diabetes must inspect their foot daily, especially after their bath. They should clean between the toes, dry between the toes, cut their nails properly so that the nails do not grow in, and also be very, very careful about using new footwear without breaking into that. Again, they must be extremely careful while going to places of worship or other places where they are walking barefoot if the surface is likely to be hot. In the follow-up visits for an individual, besides glucose measurements, there must be an annual evaluation of all the parameters. So kidney function, urine evaluation, lipid profile, and a fundus examination. This is a must. So a 3-monthly fasting PP, and if possible an A1C, an annual fasting PP, HbA1c, lipids, liver function, kidney function specifically, and a urine evaluation for proteinuria, and a fundus evaluation. The primary care physician initially should see the person on a monthly basis, but once they're stable, a 3-monthly basis is usually good enough. The fundus is an area which we often tend to ignore, because most patients say, yeah, I got my spectacles checked and I don't have a problem, or my vision is all right. But we have to tell them we are not looking at vision, we are looking at the back of the eye to see there is nothing wrong with the retina. This has to be reinforced, this has to be done, and this has to be documented, because the eye is also giving us a glimpse of what is happening to the other systems inside our body. Preconception counseling is an area which I mentioned in the passing, but I think it should be pre-marriage counseling, because conception can happen soon after marriage. And I think it becomes extremely important for a young girl to manage their glucose well. And as I mentioned earlier, sharing this information with the groom becomes important, because otherwise, without the cooperation of the new household that they're moving in, managing sugars is going to become very, very difficult. So my plea is that all prospective females with diabetes must share this information, as must the males. The only difference being that conception is an issue which is gender specific, and therefore it has implications not only for the health of the patient, as it would be in both male or females, but also has implications for the health of the fetus. Preferably, the sugar should be well controlled on an HbA1c of less than 6.5 achieved before a person conceives. Hyperglycemia will increase the risk of complications to the mother during the pregnancy and increase the likelihood of fetal complications also. So it is something which is very, very important. So before I conclude, I would like to take you through a broad framework or algorithm for screening and management of diabetes to sort of give you a synopsis of what I have mentioned in the last half an hour or so. If the person is detected by the A&M through the subcenter, your screening as part of the National Health Mission or the National Program for the Prevention and Control of Cancer, Diabetes, CVD and Stroke, all people who are 30 years or older are being screened by a random capillary blood glucose value. If the value is less than or equal to 100 milligrams per deciliter, we are not concerned and they can be retested after 3 years. If the value is 140 milligrams per deciliter or more, they should be referred to a healthcare facility where a medical officer is located. So, from the subcenter or from the community, they should go to the PHC. If the value is between 100 to 140, they should be informed that they are possibly at a higher risk for future diabetes and therefore must exercise care and caution with their diet and must do regular physical activity. Now, for the patient, as I said, who was 140 or more and they are sent to the PHC, where there is a medical officer, they should undergo a formal test to diagnose the presence or absence of diabetes. The fasting glucose values, I already told you, was 126 or more, or a 2-hour post-glucose value of 200 or more is definitely consistent with a diagnosis of diabetes. If the fasting glucose is less than 110 and the post meal or the post glucose value is less than 140, they do not have either diabetes or pre-diabetes and they can be sent back to the subcenter for follow-up. If the fasting glucose value is between 110 and 125, or the post-glucose value is between 140 and 199, this causes them to fall in the diagnostic category of pre-diabetes. So the fasting value of 110 to 125 is consistent with the diagnosis of impaired fasting glucose, and that between 140 and 199 is consistent with a diagnosis of impaired glucose tolerance, both of which are called pre-diabetes. They must be given diet and lifestyle advice because it has been established clearly that with diet and physical activity, you can prevent and or delay progression to overt disease. Now we come to the person who had on these formal tests a diagnosis of diabetes, a fasting of 126 milligrams per deciliter or more, and a post-glucose load of 200 milligrams per deciliter or more. They must be started on diet and physical activity, and if there is no response to that in the short term, metformin must be added. Now that could be 1 or 2 tablets of 500 milligrams on a daily basis. That can be tested every 4 weekly thereafter for 3 months. If the control is not adequate, you need to up titrate. In addition to starting diet and physical activity, this is also good, and the metformin, it's also a good time to do a baseline evaluation. This should be blood pressure, foot care, fundus, measurement of serum creatinine, a dipstick proteinuria, lipid profile, and wherever possible, an ECG evaluation. All of these are to be done at baseline and annually thereafter. The fasting glucose on initiation of therapy, the fasting and PP should be done, or a random should be done every 4 weeks till the sugars are controlled. If they are not controlled within 3 months, despite the effort of the medical officer at the primary health center, the person should be referred to a secondary care facility at the CHC or the subdivisional hospital, and then subsequent management would be done at the CHC. The patient, once controlled at the CHC level and stable, can be referred back to the PHC and maintenance therapy done thereafter. But it's very, very important to understand the need for baseline evaluation, the need for monthly follow-up till either glucose is controlled or we need to refer the patient to a CHC, and the need for an annual follow-up even in patients with stable disease. So let me come to an end to of this session to say that the key things that we have considered and discussed today are screening, which is ideally going to happen through a universal screening from the government, which, if you are in the range of 140 or more random glucose, the patient must be sent to the community, to the primary health center where the medical officer will take care of the rest. If a person has been diagnosed to have pre-diabetes at the PHC, they should be advised on diet and lifestyle management and followed up to see whether they are progressing to diabetes. If they are diagnosed in diabetes, they must be started on diet, exercise, oral agents with metformin as the first line of therapy, and a protocol-based monitoring, which is 4-weekly glucose assessment for at least 3 months. If sugars are controlled by 3 months, they can then follow up on a 3-monthly basis. If sugars are not controlled within 3 months, they must be referred to a CHC or a subdivisional hospital, as the case may be. If the person has significant comorbidities, very high sugars, ketones in the urine, a situation requiring IV antibiotics, severe complicated UTI, recurrent UTI, significant cellulitis, concern about congestive heart failure, or any other vascular lesion, the person should be referred to the CHC. I hope this interaction has been of use to you, and I hope that this will help you manage your patients at the level of primary care better, such that a vast majority of our patients can be managed through the good offices of our extremely accomplished and skilled and competent medical officers at the PHC. Thank you so much.